Muchas gracias a los ponentes porque se han ajustado perfectamente al tiempo y tenemos 10-15 minutos para el debate. El doctor Pawlowski nos ha comunicado que si alguien prefiere hacer las preguntas en castellano y habla despacio, puede atender también ese tipo de preguntas, aunque sugerimos que mejor en inglés. ¿De acuerdo? Doctor Miró.
Primero felicitarles a los dos ponentes por sus magníficas presentaciones. Tengo dos preguntas para el doctor Pawlowski y otras dos para la doctora Díaz. Al doctor Pawlowski, the first question would be, as far as you can shorten the therapy of the HCV infection with the new DAAs to 12, to 8 weeks, to 6, there is a point of no return. This is the first question. And the second question is regarding the HCV genotyping test. So, if we are learning the lessons that we had in the HIV field, so 15 years ago, the rescue therapy was based in the clinical sense. So the European guidelines is suggesting that with clinical sense, we can have good options for rescue patients failing to other DA therapies. But doing trials, just randomizing patients with failing for the first option to clinical-based arm or genotyping-based arm, finally, doing genotyping test is cost-effective. So are you planning to perform trials to prove the usefulness of the perform HCV genotyping test? These are the two questions for you, and please let me perform the other two questions for Dr. Díaz. Excelente presentación, solamente dos cositas. Una, ¿por qué los usuarios de drogas por vía parenteral tienen un retraso diagnóstico tan importante aún, ¿no? Es una cosa que me ha sorprendido. Y luego, y ya preparándonos para el PrEP de mañana, ¿qué proporción de homosexuales tienen infección reciente? Es decir, y por tanto son pacientes que con una buena estrategia de PrEP se podrían evitar estas infecciones, ¿no? Más que el retraso diagnóstico sería la infección reciente en este colectivo tan específico.
Okay, so your first question is about duration and is there a point of no return? And I think there is a point of no return, which is 8 weeks. This duration story is more commercial story than a really scientific story. I think for the patients, 12 weeks or 8 weeks doesn't make a difference. There is no need for very short duration, but it's part of the competition between the different drug industries to promote their own drugs. And it's been created artificially. What we see at every meeting of the data presented is that 8 weeks is probably okay if you optimize your treatment with 2 very good or 3 drugs, eventually with ribavirin, depending on the groups of patients. Every time you go shorter than 8 weeks, you lose some patients. So you will always see some studies with 10 patients who all responded, but if you extend the series, if you look very carefully at the type of patients were included, including patients are not that easy to cure, less than 8 weeks should not be used. I think anyway that we have to try to maximize the treatment rates, and this is the reason why the policy of the EASL guideline panel is to slightly overtreat patients. Because even if you have a majority of patients just need 8 weeks in your population, if you treat everybody 12 weeks, you're sure that the easy to cure but also the less easy to cure will respond. And this is something by which we avoid your second question, which is on retreatment. So I'm not a great fan of shortening therapy, and in any case, less than 8 weeks should be abandoned. So regarding your second question about rescue therapy, I think, will there be studies, that's your question, to assess the importance of resistant testing, right? That's what you asked. I think the answer is no, because we have too few patients. Everybody has a series of 3 or 4. Treat them as he thinks is good and reports in the series, and you've seen that the small studies I've shown at the end on retreatment were studies with very few patients. So we will never be able to demonstrate the cost effectiveness of doing resistant testing in this setting. I think the way we do it in my place is that we do it only for retreatment patients at baseline of retreatment, and based on the fact that we will have an open discussion, clinicians, virologists together, people with expertise to discuss what is the best treatment for these patients. If you just do it with people who are not experts, who are not able to understand the result, without a virologist being involved to explain the different mutations and have an in-depth discussion on the best indication for retreatment, I think it's useless. So if it's done and I know most of you are working in tertiary referral centers, so in your settings, This is something that can be done, should be done based on a multidisciplinary discussion. The real field, I'm not sure.
Sí. Con respecto a los usuarios de drogas, nosotros también nos ha sorprendido porque es el grupo clásico, ¿no? Sin embargo, lo que pensamos es que ahora cada vez hay menos y se convierte en una población oculta y mucho más vulnerable que antes. Antes todo el mundo tenía en mente el uso de drogas como una situación de riesgo frente al VIH, pero ahora ya cada vez son menos y quizás mucho más ocultos. También puede ser parte de la relación. Nosotros medimos el retraso diagnóstico a través de los CD4 y hemos visto que esas personas pueden ser que no se diagnostiquen tarde, sino que acudan al sistema tarde, lo que llamábamos la vinculación al seguimiento clínico. Puesto que eso también está relacionado con las cifras de CD4, probablemente sea una mezcla de ambos. No solamente diagnóstico tardío en cuanto a hacerse tarde la prueba, sino también quizás acceso tardío. Con respecto a la infección reciente, a nivel poblacional no sabemos cuál es la proporción de infección reciente, pero probablemente en HSH sea elevada. Ellos se repiten en la prueba o la recomendación general es una vez al año, pero sabemos que muchos se repiten cada 6 meses o cada 3 meses, con lo cual la proporción de infección reciente en este colectivo probablemente es alta. Tenemos puesto en mente intentar hacer algún proyecto en este sentido el año que viene, combinando tanto técnicas de STARS, etcétera, con la colaboración del Centro Nacional de Microbiología y la cohorte CORIS, pero a nivel poblacional no tenemos información.
Bueno, hay bastantes personas que han pedido la palabra y, por tanto, por favor, preguntas cortas y respuestas cortas. José Ramón.
Sí, Asunción, ¿podrías explicar cuál es la metodología para llegar al 30% de personas infectadas no diagnosticadas en el momento actual? Y has comentado que vais a hacer una metodología un poquito más precisa en el futuro.
Sí, nosotros utilizamos una metodología con un indicador muy próximo, muy aproximado, que consiste en que de la proporción de casos que nosotros recogemos de sífilis y gonococia en la red de centros de ITS, cogemos también si la persona estaba infectada o no por VIH y a ellos se les pregunta si conocían su infección antes de ser diagnosticados del momento de VIH o si se diagnosticó en ese momento. Es decir, esto es un dato muy aproximado que queremos mejorar. Actualmente el ECDC ha lanzado en septiembre un programa que se llama HIV Modeling, que es un programa estadístico para poder determinar tanto la proporción de personas infectadas por el VIH como la fracción no diagnosticada y queremos empezar a trabajar con eso. Estamos también trabajando con gente de Londres, del Imperial College, para poder estimar esta fracción, pero ese paso es uno de los más complicados de estimar en todo lo que sería la cascada.
Creo que hay allá arriba alguien, pero sí, no lo vemos desde aquí.
Federico García.
Fede, muy bien.
Yeah, so my question is for Dr. Pasolowski. It's on the same way that I think the question that Dr. Miro raised, and regarding specifically baseline RAF testing on initial treatment. Okay, we come from the HIV field. Here we have learned a lot about resistance, and we have learned something, a lot of things, but we have learned one thing overall, and this is that we have tools to prevent resistance. So I feel that for baseline RAF resistance testing, there is a role for preventing resistance. You have showed how important to prevent NS5A resistance is, okay? So actually the question is, do you think for specific populations, of course in the setting that you have talked about with virologists, clinicians, experts dealing with the information, do you think there is a role for the actual regimens for 3D or for Harvoni, for 1A cirrhotic patients to test that specific population, to make decisions on using or not using ribavirin and extending or not extending the duration of treatment? That's the question. Thank you very much.
Okay, I knew I would have this question, especially from an HIV group. There is a strong push from, I wouldn't say lobby, but some people to perform resistant testing, the HIV field because you're used to do it, the virologists because they want to sustain their jobs, and some companies in the United States that have interest in having this prescribed. And I'm a virologist. I'm doing it in my lab routinely, not for our patients, for our research and for surveillance. And this, I'm not telling you don't do it for research and surveillance, and we have a national observatory in France we have set up with ANRS, and we will report on everything, so it has to be looked at. But the question is a question of access to care. Is there anything different you would do with this information? And this is my question to you. My answer to that question is probably not. And we have tools to treat well patients from the beginning, regardless of their mutations. And I'll take an example. It's possible, we don't know yet, but it's possible that the grazoprevir-elbesvir will have in their indication the need to test for NS5A resistance at baseline for patients who are infected with genotype 1A, and do different if they have NS5A resistance or if they don't. Will you use this combination if you have to do it? My answer is no, you will not, because you have other combinations that don't need it, with very high SVR rates from the beginning. And the field will naturally go to the easiest way to go, and I have one example of this, which is a combination of interferon, ribavirin, cimeprevir. This combination of the Q80K substitution in their indication. Janssen came to us and asked us to set up a procedure to receive samples from all over the country and test them for Q80K and give the information, because nobody else was able to do it, because it's not that simple. It's not kits. It's homemade testing. We put everything together and we received 0 samples, just other treatments were used instead of this one. And I think this is what will happen. So we're in a competitive landscape with many regimens. We don't need to do it. I'm just afraid that less expert people would use the information in the wrong way. So I will keep on not recommending doing it, and I think that the market will show that if a treatment has it, it will be a major handicap and other therapies will be used instead.
Estamos muy cortos de tiempo. 2 preguntas cortitas y answer very short.
Dr. Pawlowski, is a question about ribavirin. We need to use ribavirin with certain combinations, with certain genotypes, certain patients, because it improves efficacy, but adds complexity and also, the safety issues. My question is, we must, for example, when using the 3D regimen of ABI, or when using Arboni for treatment cirrhotic 12 weeks, or when using Sofandacla for a cirrhotic 24 weeks, we need to stick to the dosing shown in the package insert, or can we be more liberal with the dose of ribavirin?
So it's a good question. I think we probably slightly overtreat patients with ribavirin, and we could probably use lower doses, but this has not been demonstrated. We don't know exactly which dose. The reason why I'm saying that, I'm referring to the old time of interferon, and patients who are responding well to interferon, genotype 2 and 3 patients, these patients had an indication of using ribavirin 800 milligram per day, and that was working very well. So I anticipate that with patients who currently respond well to everything, these patients would respond to a lower dose of ribavirin. However, it will be very difficult to demonstrate. I would not recommend starting with a lower dose of ribavirin, but I think if you have problems with ribavirin tolerance, you can dose reduce, and especially if you start dose reducing after the patient is HCV-RNA negative and detectable, will probably have no impact. But just another point of ribavirin, I think the ribavirin question answers the other question. Ribavirin is one way by which you optimize your treatment and you make the problem of resistance-associated variants not a problem. And I think ribavirin is not that problematic really without interferon. And especially in patients with decompensated disease, it's still very important, and in cirrhotic patients as well. So be comfortable with ribavirin. It's a bit more side effects, but it's very helpful still.
Ferran,
sí,
tienes 10 segundos.
Brevemente, gracias. Solamente para completar la respuesta de la doctora Díaz al doctor Miró en relación a los casos recientes de infección en HSH en nuestro centro, gestionado por Hispanosida, BCN Checkpoint, donde diagnosticamos una media de 150 nuevos casos cada año. Si tomamos los datos del año pasado, más de un tercio, el 35% del total de casos diagnosticados, la infección no tenía 6 meses. Y sí, aunque exceda el periodo de infección aguda, tomamos aquellos que fueron diagnosticados diagnosticados con una infección que no tenía 12 meses todavía son el 65%. Por tanto, creo que complementa de alguna forma esa respuesta y es evidente que la PrEP tiene que jugar un papel importante porque una gran parte de los diagnósticos del próximo año que vamos a resolver o a dar no están todavía infectadas estas personas. Gracias.
Muy bien, pues muchas gracias por tu pregunta y tu puntualización corta. Yo creo que ya estamos fuera de tiempo. Agradecemos a los ponentes las excelentes presentaciones, a todos vosotros vuestra presencia aquí y bueno, pues el Congreso continúa y muchas gracias a todos.